introduce Professor David Celermajer as our next speaker. David does not need any introduction to any audience, going back to some decades, a couple of decades ago, where he did amazing work on endothelium here with us in London and back in Sydney in Australia to build up the ACHC team and also bring the Australian and New Zealand colleagues together into a big and important operation. Multiple sort of awards and an amazing career. David, delighted that you could be with us today, and you are going to discuss with us another complex entity, Ebstein anomaly. Thank you.
Thanks, Michael. I think my talk has been taped because of dubious internet connection.
Yeah.
So I hope I'll hand over to the video.
Yeah, that's great. Thank you.
Hello. I'm David Celermajer, and I'm coming to you all the way from Sydney, Australia, and talking about a really fascinating subject, Ebstein's anomaly, risk, prognosis and guidelines. And the reason it's fascinating is because there is such an enormous spectrum of disease. You can see on this slide that it can be a trivial incidental presentation in an 80-year-old with atrial fibrillation, right up onto fetal hydrops fetalis. So it's this chameleon, a disease that has many different forms. And the reason it's got so many different clinical manifestations is that the degree of the abnormality can go from very mild to very severe. And it's because the spectrum of abnormalities depends on how severe is this problem where one or more leaflets of the tricuspid valve fails to delaminate from the right ventricular endocardium. So here you can see there's a little bit of tethering of one of the leaflets, the anterolateral leaflet or the anterosuperior leaflet, which can cause a relatively modest form, right up to the part where the right ventricular endocardium hardly forms at all, and you get an enormous atrialized portion of the right ventricle with bad distal tethering, and this will obviously be a severe form of Ebstein's anomaly. So Ebstein's anomaly continues to fascinate even 100 years after its first description. And it's very appropriate that Professor Gatzoulis has asked me to speak to you about it in the London ACHD meeting, because my first familiarization and work on Ebstein's anomaly, in fact, happened when I was working down the road from Mike at Great Ormond Street during my period of training there in pediatric cardiology. So some of the seminal work on Ebstein's anomaly and the variability of its clinical presentation actually came from those days in London. And I'll show you a couple of slides briefly on that because they are still so relevant today. So take it as read that the clinical presentation varies widely and depends on three things: the age at presentation, the anatomical severity and physiological significance of the tricuspid valve disease, and the associated cardiac lesions that can be found with Ebstein's anomaly. So here's the seminal work that I did while I was working for John Deanfield in Great Ormond Street in London in the mid-1990s. And this is a very interesting survival curve because you'll see in a moment it hides a great deal of information in this rather singular survival curve, suggesting that the survival from the time of detection of Ebstein's anomaly is a median of 25 years. But what's extraordinary about this disease is how that prognosis varies according to the age at diagnosis. And that is demonstrated on the next slide, where you can see that if you're diagnosed as a fetus, then the survival is 50% to less than a year. Whereas if you're diagnosed at age 18 years or greater, the median survival is never, because the 20-year mortality is only about 15%. So it is a disease where the survival varies massively by age of presentation. Here, the presentation is usually with heart failure. Here, the presentation is usually with cyanosis. Here, the presentation is usually with arrhythmia. And here, the presentation is usually by an incidental echo diagnosis. Now, the other thing that varies very importantly by age at diagnosis is not just the severity of the tricuspid valve disease, but the proportion of patients who have an associated abnormality. So in the fetus or in the neonate, over half of diagnosed Ebstein's anomaly patients have an important associated congenital heart disease, most often right ventricular outflow tract obstruction, so pulmonary atresia, pulmonary stenosis, or subpulmonary stenosis, whereas with presentation in adolescent or adult life, under 10% of diagnosed patients have an associated intracardiac abnormality. Now, beyond that, how do you tell the risk or prognosis of someone with Ebstein's anomaly? Well, as you'll see, a couple of diagnostic modalities are very interesting. And although I've focused most of my work on echocardiography, even the plain old chest X-ray has enormous prognostic significance. And I feel that I'm channeling one of all of our great mentors, Jane Somerville, in showing chest X-rays. But you can see all three of these patients had Ebstein's anomaly. All three of them are teenagers, but you can see the massive difference between this very high-grade Ebstein's and this near-normal heart, which of course carries with it very different prognostic implications. Now, a number of years ago, we tried to define an echocardiographic index of severity, which was taking a 4-chamber view and just working out the 2D area of the right atrium and the atrialized right ventricle, and describing that as a proportion or a ratio to the LA, LV, and functional RV. And it turns out that the grade here, grade 1 is the least severe and grade 4 is the most severe, has very important independent prognostic information from the time of diagnosis of Ebstein's anomaly. So these are two cases of grade 3, where the ratio of RA and atrialized RV to LA, LV, and RV is between 1.0 and 1.5. So with those few words about what determines prognosis of Ebstein's, being age at presentation, associated abnormalities, and some radiographic and echocardiographic indices which can be easily calculated, I wanted to move on to some guideline-based recommendations. So what do the 2018 AHA and ACC guidelines say about diagnosis and therapy? Well, what we're going to cover in this talk is when is appropriate timing for surgery, the question with which we all struggle, because many of the patients look much, much better than their echocardiograms and tell you they're asymptomatic, even though they have huge atrialized right ventricles. Does it matter how old the patient is in making this recommendation? Is it ever too late to operate? And if so, when? And if you decide to operate, what operation is better? Repair or tissue valve versus mechanical valve? And does it matter what center that's done at? Does experience count? So what do the guidelines tell us? Well, with diagnosis, there are a couple of important diagnostic guidelines, although they need to be taken with a slight grain of salt. The first is that in adults with Ebstein's anomaly, cardiac MR can be useful to determine anatomy, right ventricular dimensions, and systolic function. Now, one of the tricks about that, of course, that systolic function of the right ventricle is traditionally quite difficult to diagnose, and it's all the more so in the presence of Ebstein's anomaly, where the delineation between the right atrium and the right ventricle, and particularly defining the dimension and systolic function of the right ventricle, is very difficult, even in an anatomical sense. But that's made all the worse because the degree of tricuspid regurgitation obviously influences the way the systolic function of the RV looks, and that might be artifactual. So in the same way that the left ventricle always looks better than it really is with functional mitral regurgitation, a right ventricle systolic function might look better than it is on CMR, even if you can measure it accurately in the presence of severe tricuspid regurgitation, because the TR jet has lower afterload than the pulmonary outflow tract. Now, another recommendation with a 2A categorization is that TEE can be useful for surgical planning if TTE images are inadequate to evaluate TV morphology and function. Just a word of warning here is that the tricuspid valve is often distant. The tricuspid valve is distant from the esophagus, and so TEE pictures may also be uninformative or at least minimally informative, particularly for the anterosuperior leaflet and its distal tethering points. So sometimes, paradoxically, TTE might be better for some aspects of surgical planning, and CMR in multidisciplinary meetings is often a useful adjunct. Now, with therapies, it's worth going through these because a lot of thought went into this, and they're very helpful. So the first recommendation is a class 1 recommendation, which is that surgical repair or reoperation for adults with Ebstein's anomaly and significant TR is recommended when one or more of the following is present. Either heart failure symptoms, which of course have to be due to the tricuspid valve disease, objective evidence of decreasing exercise capacity on formal CPET testing, and progressive RV systolic dysfunction by echo or CMR, just remembering that interface that we were talking about a moment ago between progressive TR and RV systolic function. So sometimes with progressive TR, the RV can look the same, but in fact, RV systolic function or capacity is not as good because the TR has worsened. Now, there's a 2A recommendation that surgical repair, forgive the typo there, or reoperation for adults with EA, can be beneficial in the presence of other indications beyond heart failure symptoms, decreasing exercise capacity, or progressive RV systolic dysfunction. And they are progressive RV enlargement, systemic desaturation from right to left atrial shunting, because of course a PFO or an ASD is going to shunt right to left if there's significant obstruction to flow at the level of the tricuspid valve or the RV outflow. Paradoxical embolism and or atrial tachyarrhythmias are also relative factors that should be considered in the decision-making for Ebstein's anomaly surgery. So what about the Mayo Experience? They have by far the best and longest experience in interventions for Ebstein's anomaly. And some of my slides have come with permission from Carol Warnes. And I just want to say one caveat about the Ebstein's experience at Mayo, and that is, firstly, that they're a quaternary referral centre, so their base of experience has some referral bias. They tend to get worse cases, which is important to remember. And the other is because they do so many cases, they have particular expertise with surgery that may not be replicable in every other institution around the world that has lesser experience and expertise. But having said that, these are the Mayo indications for operation. Symptoms, particularly fatigue, but in the presence of decreasing objective exercise capacity, that's often regarded as an indication for surgery. Cyanosis, as we covered a moment ago, and decreased exercise tolerance, not subjectively defined, but objectively defined. Progressive RV dilatation, and the onset or progression of arrhythmia is a common indication. And of course, the tricuspid valve surgery then would be accompanied by anti-arrhythmia surgery and or the placement of an electrical device, either a pacemaker with or without defibrillator capability. And what Carol and the generations of surgeons from Gordon Danielson onwards have been at pains to point out to the rest of us is that the timing of surgery should be before there's significant RV systolic dysfunction. And of course, that is a paradigm that we're very used to on the left side of the heart, where both aortic regurgitation and mitral regurgitation surgeries should be carried out before significant LV systolic dysfunction. The trick on the right side of the circulation, of course, is that the surgery for Ebstein's anomaly is often more complicated because of the severity of the tricuspid valve anatomical abnormality. And of course, they also make the point that if repair is more likely, and in their last series of cases reflecting the last 3 or 4 years, they can almost always repair the valve with a cone repair, which I'll illustrate in a few moments. Earlier operation is indicated. So what are their results? Well, between April 72 and December 2015, they operated over 1,000 patients. And of course, that covers an enormous spectrum, both in anatomical severity, associated lesions, and there's an era effect from the earliest surgeries, which were tricuspid valve replacements, through to transverse plications, longitudinal plications, relamination and monocusp type repairs, and most recently the cone repair. But let's look at the totality of their experience, noting that for the last 10 years or so, they've mainly done cone repairs and reported those with some substantial follow-up from December 2015. So as we've come to expect from this centre of excellence, the early mortality is very low. And with the cone procedure in the expert hands of Joe Dirani and his team at the Mayo, less than 1%. This is not replicated in every other centre, but this is the Mayo experience. So here's the overall survival from this very long experience, and one might expect it might be even better if you take contemporary data from the cone experience. But with all comers here, you can see a 10-year survival of 85% and 20 years of over 70%. Now, that's survival. What about freedom from reoperation? And those data are pretty good, although obviously not quite as good. In fact, in this experience, the 20-year reoperation rate is a tad over 50%. Now, as the Mayo do, they've done a sophisticated multivariable analysis about the predictors of late mortality. And many in the audience will know that the left side of the heart is terribly important in prognosis with Ebstein's anomaly. There's quite good data from our group and others about left ventricular fibrosis that occurs in babies and children with Ebstein's anomaly, which many of us regard not just as a disease of the right heart, but importantly of the left heart. But here you can see that substantial mitral regurgitation or moderate LV dysfunction is associated with a higher risk, in fact, than moderate RV dysfunction. And so the left heart needs to be considered, even though it doesn't appear specifically in the guidelines. And as the Mayo folks say, and I think that's borne out by most centres that do a lot of this, including Cleveland Clinic and Toronto, not waiting too long, especially if there's an operation that can be done at very low perioperative risk. So what about if you're over 50 years of age? Is it too late to operate? Is the damage done? And here in carefully selected cases, again reported by the Mayo Clinic, although the observed survival is not as good as expected survival, there's a 70% 10-year survival rate, even in these older Ebstein's anomaly. And by and large, they've been operated for the type of class 1 indications that we reviewed earlier, which is progressive heart failure, progressive exercise intolerance, progressive arrhythmia, or progressive RV systolic dysfunction. And just noting that this was a particularly unwell group, that 85% were functional class 3 or 4 at operation, and 89% had an improved functional class 1 year after their surgeries. What is the cone repair for those of us who are less familiar with it? Well, it's shown on this slide. It's basically where in panel B, you can see that the anterosuperior leaflet is delaminated from the RV endocardium. It is detached, and then it is rotated clockwise such that the redundant leaflets are pulled together in a way that restores a more normal-looking tricuspid valve, and the transverse part or the lateral part of both the right ventricle and the atrialized right ventricle and the right atrium are plicated to restore the function. And the reason it's called a cone operation is that the surgeon goes down in a cone shape from the lateral wall of the tricuspid valve annulus, the true annulus, to release the anterosuperior and posterior leaflets of the valve to restore that kind of physiological function that you can see in panel D. So that's the cone repair. Now, there's another operation that we should talk about briefly, and that's a bidirectional Glen shunt, which is often done in addition to tricuspid valve surgery in severe Ebstein's anomaly to try to reduce the load on the right ventricle if it looks inadequate. So why would you do it? Well, it's to decrease the venous return to the RV by about 1/3. So it's usually thought to be indicated with severe RV dysfunction, where it's not thought that the RV would cope with the entirety of the systemic venous return. It might be considered when there's a smaller tricuspid valve annulus, which is causing tricuspid valve stenosis, which of course is very difficult to repair even with the cone operation, and really can only be repaired with a tricuspid valve replacement. And sometimes cardiac catheterization is very helpful in determining who should and shouldn't have a bidirectional Glen procedure for these reasons, to measure the RV end diastolic pressure, remembering that cardiac catheterization could be arrhythmogenic in patients with severe Ebstein's anomaly, and that most of the information can now be gained either by pre-procedure echo and MRI, or the decision might be made by an experienced surgeon at the time of the procedure, depending on how the tricuspid valve looks after repair. So sometimes it's done as a perioperative decision by the surgeon. Now, what about the recommendations for Glen shunts? Here you can see a 2B recommendation that a bidirectional SVC anastomosis is done at the time when there's severe RV dilatation or dysfunction, when LV function is preserved, of course, just like in a Fontan circulation, and when the LAP and the LVDP are not elevated. And of course, that's information that can be gleaned from cardiac catheterization. Now, when might conventional surgery be too late? This is a very difficult thing in clinical practice, because maybe there are some hearts that are so bad and the LV is dysfunctional and the arrhythmias are bad and you might consider a transplant. Well, there are no guidelines yet, but this is what I think the state of play is in 2020, that with Ebstein's anomaly, in the appropriate expert hands where surgical results are good, and you have to make that decision in your own setting or refer onwards, one should intervene if there are symptoms, decreasing exercise capacity, progressive RV enlargement or dysfunction, an important right to left shunt, or progression of arrhythmias. What are the gaps in our knowledge? Well, the choice of valve is really an untouched area, but should be made from first principles, as we're all familiar with in adults with congenital heart disease, not all of whom would cope well with formal anticoagulation. It's still unclear when it's too late to operate or when to transplant. And it's still unclear when pre-operative EP study and RF ablation should be undertaken prior to surgery or even to delay the onset of surgery. So as you'll see, Ebstein's anomaly continues to fascinate because there are important advances, particularly with the surgery, but still gaps in our knowledge where the art and the science have to be combined with the patient's wishes to come up with the best patient outcomes. So watch this space, and thank you very much for your very distant and very virtual attention.
Thank you, David. Great talk and spirit. For, as you say, a fascinating lesion of the whole heart. It's not just the tricuspid valve with such a heterogeneous spectrum and covered a huge field here. While we're waiting for questions from our delegates, and just to remind everybody that if you go to the live question and answer session to the right of your box on your screen, then you can ask the questions that you wish, and then you can prioritize too. But I have a question for David. I wanted to ask also for Grusin. If you got a 17-year-old patient with Ebstein anomaly coming to your clinic, transition from pediatrics, and that patient is contemplating pregnancy in a few years' time, what is the advice that you would give to the patient, David? This is native Ebstein's, not mild, not extreme. Thank you.
So, Michael, I've often found that formal exercise testing is quite useful in prognosticating pregnancy-related risk. So one of the first things I'll do after the usual chat with the patient and why a 17-year-old wants to get pregnant, which is a separate issue. But I think formal exercise testing and just keeping an eye out for cyanosis, because as you know, cyanosis is poorly tolerated by the fetus in pregnancy, and sometimes PFO or ASD closure can resolve the problem of cyanosis and make a pregnancy much easier. But I think that a thorough history, careful physical exam, chest x-ray and an echo followed by an exercise test makes that decision-making a little bit easier.
Thank you, David. And I think a question pertaining to this that George Anakoulos is asking from the Aristotle University of Thessaloniki in Greece. Again, as it happens, a 17-year-old patient coming to your clinic with a paradoxical embolus and a small ASD, with moderate severe Ebstein's, but not decompensated heart failure. What would you do, David?
Yeah, so I almost always would close that. If the ASD were technically suitable for percutaneous device closure, I would do a test balloon occlusion at the time of cardiac catheterization to make sure that the right atrial pressure didn't rise. And if the right atrial pressure didn't rise and the defect were technically suitable for closure, I'd close that, because I think that long-term anticoagulation in a 17-year-old, particularly a young woman, has a lot of difficulties. So if the defect could be closed, just like I would in someone with recurrent stroke of uncertain origin where there was a PFO indicated, I think that's probably a very reasonable option.
And just to be devil's advocate here, David, if the patient had significant tricuspid valve displacement with severe tricuspid regurgitation, so moderate to severe end of the spectrum, my traditional sort of thoughts with trainees here and the team is that you should not be addressing in this situation just the septum, but also the valve if you are to operate. Is that a consideration for you, David?
Oh, absolutely. I think if it's a bad Ebstein's and it meets any of the other indications for surgery, but I've just got to say that the center is particularly important. I think if there's a surgeon that it's doing 2 cone procedures a year, that's a difficult operation. But if it's a center that's doing 15, that's a different thing. But I agree completely. The other option is to repair the tricuspid valve and close the atrial septum at the time of open heart surgery.
Yeah. Thank you, David. Much appreciated. I don't see many questions at present, but as we are warming up, I think, with the meeting, so the right of your screen, live questions and answers. I think it is important that we have a bit of a break and we have a lot of surprises for you and a lot of interaction to make it not just presentation and discussion, but other elements of the meeting. So stay with us. But before you go, may I ask you to do a live poll for us, please? Would like to know how many of you are exclusively ACHD aficionados? Yes or no? So there is a poll, live poll, that you can tell us about it, and we will let you know the results when we come back from our sort of brief comfort break. May I suggest that we reconvene in 8 minutes, please, because David cannot stay for the duration of the session, but he's going to introduce and handle the next talk by Professor Dimopoulos.